Thank you. What an introduction. Thank you very much, John. And I feel incredibly humbled to be speaking after some of the previous speakers, particularly the gentleman talking about the October the 7th incidents. I certainly haven't been experienced anything like that, and I'm not going to talk about mass casualties in that type of way. I am going to talk about mostly our experience from the UK, but what we've learned from the international events as well. Particularly, probably my favourite term at the moment, which is casualty flow acceleration. And I think that probably picks up on a theme that's been talked about this morning, which is time. Now, major incidents nearby to here, if we're talking about being in Switzerland, just over a month ago, there was the fire in Crans-Montana, which I've probably said wrong, so I'm sorry. That, obviously, we've had a huge number of incidents across Europe. I am going to focus on the UK incidents, which is where I have the most knowledge. And in 2017 was when we had most of our incidents. Recently in the UK, one did include the Grenfell Tower fire, and we also had the terrorist attacks. Prior to that, we'd had the 2005 7/7 attacks, which everyone will hear about. But actually, when we look at all of those attacks, you could argue that were we really tested in terms of the numbers of injured and dead? If we compare it to things like Madrid or the September the 11th attacks, we really didn't experience that level of mass casualties or the level that they experienced on October the 7th or that we're seeing in Ukraine. And we certainly don't or haven't had issues with drone attacks and evacuation of patients in that way. And when we're thinking about mass casualties, I think the things we prepare for daily, certainly in the UK and across a lot of Europe, is probably more the multiple casualties, the tens, hundreds of casualties, as opposed to the thousands of casualties. But the decision-making will vary, and what becomes a proper mass casualty event, where the numbers change from multiple casualties to mass casualties, I don't know what that number is. But when we're talking about the potential for thousands of casualties on the streets of London, I think some people think that that's not a reality. This was actually a headline the day before I gave a talk about this in Australia just before Christmas. And I think we may, a few years ago, thought that wasn't a reality, but I think it probably is a reality, but something certainly in the UK that we're probably not as prepared for as we should be. Now, other countries, I think we've probably got people here from Sweden. Sweden and a lot of the Scandinavian countries are much more prepared than we are in the UK, and they have a booklet to tell them what to do in the case of war and how to prepare, how to manage each other as casualties and how to stockpile, and that's something that we haven't done yet in the UK, and we probably should be more able to prepare the population for. I'm going to talk more about our experience of the thousands of casualties and more the tens of hundreds, and how we've looked at those incidents across the UK. And I think we have had a mindset switch over the years from just doing the most of the most and saying that anyone who's not breathing is dead, to looking at what each patient actually needs. And we've had inquests and inquiries that have looked in detail at all of those casualties. Lady Justice Hallett was the first one to look at the 7/7 inquest, and then Sir Mark Lucraft and Sir John Saunders looked at the 2017 attacks and one of the 2019 attacks. And it's not easy for anyone going through those inquests because there's a huge number of questions asked, and actually the police teams involved who've compiled the data, exquisite amount of detail for every single casualty that died, and that actually highlight that because that's the sort of data that we should be knowing about before it gets to 5 years after the incident and the inquiry happens, and actually probably much longer than that with some of the incidents before we get any of the answers from the inquiries. But what it also has done is allowed us to look at what the expectation of the families are. This is Jack Merritt. He died at Fishmongers Hall. He did have our team attended to him, and he had enhanced interventions. He had a thoracotomy from the HEMS team who went into the warm zone, took him out, performed a thoracotomy because he'd lost signs of life a few minutes before they'd got to him from a chest stabbing. Excuse me. They didn't find anything they could fix easily. He had subdiaphragmatic bleeding and nothing that they could do anything about in the chest, and so they quickly moved on to RSI and give blood and arguably save the life of another lady who was injured. But Jack's family know that he had everything possible done there. And that is the lens through which most of these casualties will be looked at, even if in the context of the incident, we know that maybe it wasn't possible at the time. And that also brings me on to one of the things that was highlighted, certainly from Manchester Arena, was the fact that a lot of the families were not comfortable with the idea that people just put a dead tag on someone without considering whether they had the opportunity to save them. And that's one of the reasons why when we developed TST, we put in the not breathing, partly also for the responders, to make the decision that someone is dead and doesn't have the capability of being resuscitated when you don't know the extent of the incident or what your resources are. It's quite a difficult decision to make and probably shouldn't be made in a few seconds. And that also translates into the training. So do we really train for these incidents properly? This is Gravesend, which is the police training centre in London, and one of the incidents that we've had multiple training incidents like this with these faceless sandbag mannequins. It's easy to just put a dead tag on a faceless sandbag mannequin without thinking about what that means and the implication when you go home that night. But does that really prepare you for training for real people? Even when you dress them up in police uniforms, these are still blow-up mannequins that I don't think people really believe are people they're treating. And when anybody walked into that city room, this is Manchester Arena, this is probably about 45 minutes after the bomb went off, but you listen to the reports of everybody who talk about responding to that incident, and all of them describe the overwhelming nature of walking in with the sounds, the smells, the body parts, and then you've got the father of the person you're resuscitating standing next to them. And as a police officer, you're not going to stop resuscitating that person until you've at least got a healthcare professional there. So how do we prepare people mentally to do that? And even if you are well trained, this is an extract from Matthew's book. Matthew Langlois is the chief medical officer for the raid who went into the Bataclan. And he describes, despite this being the thing he trained for, when he walked in there, he felt completely overwhelmed and had to really get over himself to get on with the job that he knew he needed to do. So we know that the emotional response is going to be a thing, and the best we can do is really try and have authentic major incident rehearsal so that when we do rehearse for these things, we think about what our emotional response will be like and the decision making that we're going to have to make when we get home that night. Very briefly, I know I talk about hot zones quite a lot. I'm only literally going to talk a few slides about hot zones today, because actually the medicine is the same whether it's a hot zone or not. It's just the hot zone makes it more difficult if it stops you getting in and stops the resources getting in or getting the patient out. And hopefully in the UK, the joint operating procedures for certainly marauding terrorist attacks is official sensitive, which means that everyone needs to know it, but it's not as accessible as it should be. So briefly, the London Bridge attack that most people will have heard about in 2017. The attackers drove over the bridge and came back again, hitting a load of patients on the bridge, and then crashed their van into the corner of the Barrowboy and Banker pub, ran through Borough Market stabbing patients until they were outside the Wheatsheaf pub, when this video just shows that one of their final victim, and you can see the force in a few seconds with which they were attacking that victim, which was reflected in the post-mortem reports, which showed multiple rib fractures and the length of the injuries to the patients. This is 8 minutes from the beginning of the attack. And the police have neutralised the 3 attackers. Obviously, everyone just comments on the fact that they don't put the handbrake on the car, rather than what they're doing. But the point being, just to put you in the perspective of, this is Borough Market. If anyone knows that area of London, it's a super busy area of London. And so even though the 3 attackers were neutralised there within 8 minutes of the attack starting, that whole area was hot for 12 hours because they thought there was a 4th attacker. Now, there was actually no drive for there to be, there was nobody seen with a weapon known to be, there was no gunshots reported. But this remained hot because of what happens in a lot of these incidents, which is the false information that comes through. Someone thought there was an attacker from the north side of the bridge. Lots of other things happen where no one's sure, but actually there's no direct impetus for there being another attacker. So one of the questions is it actually a hot zone where there's a direct threat to life? Because if it is, clearly you can do minimal care. But actually in a lot of these cases, it's the people making the decisions that it is hot or not, and it comes down to their experience. And this is a quote from Manchester Arena from one of the fire officers that attended. I think it's just quite pertinent to remember that one of the things that stops you going in is calling it a hot zone. And if it's not a hot zone, then maybe we have to think. And for Manchester Arena particularly, the bomber had blown himself up and there were no other attackers. So the risk was of the building safety or any other fires. And although there were potential for attackers, the armed police had cleared that building pretty quickly, but that information probably wasn't passed clearly to the people that needed to know it. And so communication at these incidents is one of the problems that is repeatedly picked up in the inquests. And just a thought that maybe rather than hot, warm and cold zones, we could talk about what the risk is. So what is the threat? What's the attack methodology? Therefore, what is the remaining threat? And do we think it's safe enough to go in as opposed to blanket zones that don't give you that information to make the risk-benefit decision for yourself? But coming back to Manchester Arena and the city room, I'm going to talk about some of the learning that we have from a couple of the patients who died. So John Atkinson was 28 years old when he died. He died from essentially compressible bleeding to his legs. He had multiple fragmentation injuries to both of his legs, with a lot of damage to the musculature, to the blood vessels, multiple fractures. His legs weren't amputated, and that may have been part of the problem why people didn't recognise that what he needed was tourniquets. But the chairman said if he'd had medical tourniquets put on earlier and if he'd been evacuated earlier, he would have survived. Those blood tracks that you can see in that picture are from John's legs. John pulled himself from the middle of the city room to the edge of the city room, all the while talking to people. A bystander put a belt on one of his legs. He was eventually carried out by police officers and bystanders on a barrier and hoardings. They couldn't get him in the lift. It was too uncomfortable and difficult and too big. So they carried him down the stairs and he got to the casualty clearing station still alive, and then went into cardiac arrest in the casualty clearing station. And although he had a temporary ROSC, he didn't survive. And the chairman said he could have survived if the response had been different. Safi was a little bit more complicated. She was 8. She got to hospital nearly just before an hour after the explosion. She was taken out, again by bystanders and police. She had multiple injuries, and she definitely also had compressible injuries to her lower legs. She had the named blood vessels in her post-mortem were the popliteal vessels. However, she had multiple fractures from fragmentation injury as well, and she also had some blast lung injury, and a fragment had gone through her liver, but no blood in her peritoneum. Now, her injuries were highly debated by about 11 experts at the inquest, but in the end, the chairman said he thought that there was a chance she could have survived had she had earlier treatment. And he did say that he thought it could have been if it was an enhanced pre-hospital care team. I think that's because he thought that the identification of the injuries and what she needed was difficult. All of that is available in the Volume 2 report of the Manchester Arena inquiry, and that's really helpful for us to know about, because we can start to try and learn from that. None of this is published in the medical literature, and if we look at the other incidents like London Bridge, you have to trawl through the whole hearing transcript to find the specific injuries that had caused some of the deaths. It's not published in the medical literature. In fact, as of the beginning of this year, there are only 9 published papers on civilian terror, intentional attacks or mass killings, in terms of actual type or cause of injury and method of the patient deteriorating. So we didn't actually have much published evidence on what that is. And talking about survivability, one of the things we've looked at in our research project is what is survivable. And if you look in the literature and you look across the world, there's no one agreed definition of what survivable is and what's the difference between survivable and a preventable death. I won't go into all of the details on what we've looked at, but we spent a couple of years looking at this, and the conclusions we came to were that we feel the best definitions of this are almost split in 2. So the first part is that anatomical injury survivable in the best ideal circumstances? And then the next question is it preventable in the circumstances of that incident, patient factors included and resources included? So the bit about the survivable is in ideal circumstances. So if we can learn what we could do better in an urban MTC, so for the UK, in an urban trauma system, with everything you would want as quickly as you could possibly get it, could this injury allow a survivor to get to hospital with a chance of life? And what would the narrative be that would allow that to happen if it hadn't happened? And just while we were thinking about this, and also while I was looking at some of the evidence from Manchester, I realised that there were some experiences I had from working in Afghanistan. A lot of people, certainly in the UK, haven't managed blast injuries and don't know what's survivable from a blast injury point of view. So just a brief example of a patient we went to in the middle of the night on the Mert. We were with them 40 minutes after injury, on scene for just long enough to get them on the back of the Chinook and fly them back to Bastion. So we had the 15-minute treatment time to get them back to Bastion an hour after injury. And this was a patient with bilateral amputations. This was not an uncommon injury, and we saw this all of the time. And also, though, he had facial injuries. So as well as that bilateral amputation, his facial injuries, he'd got a fragment through his left orbit, which had caused a penetrating fragment of bone and metal to his frontal lobe. So while he was being resuscitated, we didn't have neurosurgeons at Bastion. His scans were sent to Kandahar, and then he was taken from the scanner to the operating table. And interestingly, his physiology was normal, which doesn't really help us work out what's going on with him. So until he got perfusion when we resuscitated him with enough blood, he then had SATs traced. But apart from that, his blood pressure and heart rate were completely normal throughout. And this was him on the table. So he had the general surgeons providing proximal control while the orthopods fixed both legs and completed the above knee amputations. He had his fingers and hands, the finger amputations completed, and he had his left eyeball removed. The brain was crudely covered, and then he was taken to Kandahar for neurosurgery and was flown back to the UK within 24 hours. Apart from the complications of having a brain injury and needing to be anticoagulated, with all of the other trauma, that was probably not a standard case, and he probably got about 20 units of red cells and FFP. Now, the harder cases were the higher amputations. This is a really high thigh amputation, and those are the ones that we slightly struggled to manage, certainly if we couldn't get the tourniquets high enough and they had some pelvic injury as well. But a patient with a similarly high amputation, in fact, 2 leg amputations that were similarly high, as well as hand and arm injuries, was Lee. He was 20, and he came in peri-arrest into the ED, had a trauma line, blood, a thoracotomy, aortic control, and went straight into the operating theatre for surgery. And he actually stabilised really well for 30 minutes on the operating table with a clamp on his aorta still. But at that point, he started to drop his blood pressure. I noticed at that point his CVP was high, and then he arrested. After 11 minutes of doing internal compressions, we were about to stop, and I looked at his heart, and his heart was hugely distended. So I said to the surgeons to remove the aortic clamp, which they did, and that didn't help. And eventually I said, well, maybe put a catheter into his right atrium to drain that right atrium, which they did. And as his heart emptied, it was able to start beating, and he got good contractility. He needed inotropes and some GTN and a mixture of the two to manage his afterload as well as his contractility. But after 60 units and some intensive care, he was stabilised and flown back to the UK. And these are some clips from the Mirror that his mum had talked to them about. Essentially, he did well. The only thing that bothered him was his nose when he woke up, but actually he got over that. The point of that is just to explain that triple amputation, even with a peri-arrest scenario and probably secondary injury to the heart from being, whether it was blast or whether it was just trauma, we don't know, is survivable with the right circumstances and the right treatment. I take you back to 7/7, which was only 5 years before that case in those cases in Afghanistan, and tourniquets weren't used. It was different, potentially, because a lot of those blast injuries were in open space in Afghanistan, and this was blast injury in an enclosed space. But we had no internal post-mortems to know what the effects of that blast were, or to know the effects of the fragmentation. Now, the inquiry said that on the balance of probabilities, no different treatment could have saved any of the patients there, and that there were no preventable deaths. But we know from open source literature that 17 of those 52 didn't die instantly, and some of them were alive for up to 2 hours. Lee Harris and his partner Samantha were on the tracks calling for help. They were carried up eventually up the stairs at King's Cross. Lee got to hospital, Samantha died while she was being carried up the stairs. But you do have to wonder that we might have found out more if we'd known about the causes of death from the post-mortems. So how do we better learn from these incidents and better prepare to achieve a situation of no preventable deaths, as well as limiting pain and suffering and minimising morbidity along the way? And we need to understand the causes. therefore the interventions we need and how much time we have to do that in. I'm going to focus particularly on time, and this idea that there's a window of opportunity that opens a later window of opportunity. So for some casualties, we know they have less than 10 minutes. For some, we know that they're unsurvivable, whatever, because that injury we think is not fixable. However, and some will be fine. But for those that have a window, a limited window, are there interventions that we can do to extend that window so that maybe we allow them to get to the place that they get the definitive care in the end? For instance, Safi. If Safi had had tourniquets put on her legs in the city room and potentially splints to pull out the muscles and try and limit the bleeding from her multiple fractures, then if she'd had that done immediately, she could have got to hospital in a really good or much better state. Even if she'd had it done a bit later but then had IV access and blood, she could have potentially got to hospital in a better state to get to the operating theatre without arresting on arrival. I think Cosmo later is going to talk about a case that we had in London. We have a lot of these where the police get there. If they put the tourniquet on early and the patient's still awake, then that patient has a large window of opportunity later. If they put it on later, they have a much smaller window of opportunity, and they need us as a HEMS team to get there and do more to get them to hospital alive. And in his case, they'd actually got to the point of arrest, so needed blood thoracotomy and a Ribera. But this concept of windows of opportunity is something to focus on, and to give people some sort of framework to know how to approach a room like the city room. Even if you know what to do, how do you get over all of the things going on in your head? To have a simple approach is one of the reasons that we invented TST, 10 Second Triage, as an early scene triage tool. And with that, the intention was to keep it simple, to maintain people's bandwidth and allow situational awareness to be maintained. It was originally developed with police officers who would need to switch between being an operator and doing the medicine and switching back again. And so we removed the physiological measurements and replaced it with simple questions that essentially assess the end organ effects of that physiology. And the questions being, are they walking? Is there any severe bleeding? Are they talking? Are they breathing? And importantly, the blue diamonds pick up on the preventable deaths. So what interventions do we need to do in that first few minutes to prevent death, then open the windows for further treatment later on? And the terminology, we changed catastrophic hemorrhage to severe bleeding for the reason of patients like John, where people maybe, it's possibly a training scar, but there's a lot of misconception that catastrophic bleeding is only spurting up the wall bleeding. I think we all know that it's not. It seeps into the floor, it seeps into clothing. Sometimes it doesn't even come out of the legs if it's contained within, there's no amputation, there's no big hole in the tissue. And now we accept that may result in a lot of tourniquets being put on that aren't needed, but we'd rather they were put on and reassessed early than they weren't put on at all. The talking bit seems simple, but actually nuanced. It's, are they talking normally? Some of you will have seen a video of Vicky Lebrecq, who was one of our early Ribera patients. And Vicky, if you see her video, and you can just see her pictured there, she's talking. She's not talking normally. She's very starey. She's looking into space, but she does answer Simon's questions when he asks her how she is, and she says she's got pain. Now, Vicky is that bleeding patient that has the altered sensorium of the hateful eight that we talk about, and that is the not talking normally. And we think that will help us pick up the blunt injured patients as well as the penetrating trauma. And then the head injured patients who've got an expanding extradural will also not be talking normally because they'll be confused, and we think that will help pick up those patients. And then the penetrating trauma patients, this is a picture from Las Vegas, Harvest Festival shooting. We know we've got lots of evidence from military and civilian literature that tell us that non-compressible torso hemorrhage, particularly from penetrating torso trauma, is one of the leading causes of preventable pre-hospital death. And we wanted a way of picking that up. So if the patient is a P2, so they're talking normally, but they've got penetrating injury in that area, they become a P1. So the point of this is to initiate those early life-saving interventions, open a window of opportunity to get the patient to the next stage, and to prompt movement, early movement of casualties to the CCP, P1s first. But the important bit is moving patients, and police can do that without ambulance and fire directing it, particularly without ambulance directing it, to start that casualty flow. One of the things we've seen repeatedly in these incidents is a lack of billet stretchers to move people. On the right is the Bataclan, and on your right is the Bataclan, on the left is Manchester Arena. And in both of those incidents, everybody was carried out of either the city room or the orchestra pit on barriers and hoardings, which takes 10 people rather than 3 or 4, is much more uncomfortable for the casualties and takes much longer. So one of the things we should think about is not having that lesson learnt again with future incidents. Now, a question that I'm often asked is about TST making everyone P1s. So if it's a penetrating injury, there's lots of chest injuries, everyone's a P1. That sort of is the point, because that's not easy to write into an algorithm about which one of those is the sickest. And it leads me on to the point about what happens next. What happened at Southport was they had enhanced care teams that went in there really quickly to work out which of the children with penetrating injury to their chest were actually sick and needed something. And the same thing happened at Huntington. So having the enhanced care teams much further forward than we might have expected in the past to make that decision, that intuitive triage decision about which P1 is actually a P1 or the P1iest, which one needs something to get them to hospital alive. And that's probably the biggest thing we bring as an enhanced care team to a major incident, is that intuitive triage concept of a P1 plus. Which ones need something to get them to hospital alive over the other P1s that actually will turn out to be quite stable. And in London, we're putting HEMS P1 plus orange tags on the P1s that we identify being those patients, and to rapidly speed up their movement through the system to get to hospital. So these flow accelerators, there are things that accelerate casualty flow. The tagging, the TST, starting the P1s moving, carry sheets and analgesics are really importantly, because some patients are trapped by pain. And then coordinating that evacuation with some clinical direction as soon as that can happen to really drive that movement. And maybe the patients that need to just bypass the CCP and get straight to hospital. And there are things that decelerate flow, calling it a hot zone when it's not. Poor communication, having 3 separate services, if the communication doesn't happen and everyone's got a slightly different mental model, can slow things down. And again, that lack of clinical leadership. Casualty flow acceleration is really the key, I think, to improving outcomes. And I'm really pleased to hear that other people seem to agree with that thought as well. And trying to move that patient to definitive care if you can, because particularly the ones that are savable, we know we have limited time to do that. And we're all human, and often even if we know that, the thing that stops us doing it is our emotional response to it. So we have to think about how we get over that and how we have simple systems to help us make that happen. This is a picture of the memorial at Bastion that we used to have the repatriation ceremonies around for the patients we couldn't save. But we have to learn from those patients that we can't save. And from the 52 that died at 7/7, we should have learned more from them as well. So for the future, we really should have accessible multi-agency data sharing where we learn everything about that patient journey, both from the police data, the health data, and the forensic pathology data, which we don't always easily access, which should allow us to then have standardized data sets, better patient identification, which I haven't touched on, but is a huge problem for us in the UK, is really knowing which patient is which and getting all of that data together to know it belongs to that patient. The publication of the data so we can allow the learning, embedding that learning into practice, which we're still not seeing necessarily from 2005 to 2017 and arguably to now. On a slightly happier note, coming back to my patient who had the bilateral amputations and the facial injuries, his patrol was going through a low door and the IED went off. He was the last one to go through the door. It's the 5th time they'd been attacked. And he went through last and it went off in his face and caused his amputations. Ricky Ferguson recovered really well from his amputations. He was walking on short stumps, then prosthetic limbs. He had an abdo skin graft to his face, had a tracheostomy while he had that done. And then he had rehabilitation at Headley Court, which was our military rehab facility at the time, which was residential and is now Stamford Hall. And in 2012, he carried a torch for the Olympics and was given an MC by the Queen. So to end on a slightly happier note before the break, we should learn from our patients that die, but also our patients that survive, and identify the things that allow them to survive to know what we should do for the future. Thank you very much.